So hello everyone and welcome to this important session on laryngeal carcinoma reporting. So this is the second most important malignancy of the head and neck after oral carcinoma. So, so we'll start with the anatomy of the larynx first on imaging so that we understand the extent of the disease spread and we can stage it properly. So the larynx is an inferior continuation of the oropharynx and it extends from the epiglottis to the inferior aspect of the cricoid cartilage. And inferiorly it continues as cervical trachea. So it forms the upper respiratory tract. So it consists of cartilage or skeleton as well as internal structures that are divided into three subsites: supraglottis, glottis and subglottis. So this particular division is very important for us in imaging because all the staging differs according to which part of the larynx is involved. So supraglottis extends from the tip of the epiglottis to the laryngeal ventricle and it consists of epiglottis, pre-epiglottic space, arytenoid cartilages, aryepiglottic folds, false vocal cords, as well as paraglottic space. Well, glottis consists of true vocal cords, anterior and posterior commissure, and subglottis extends from the inferior surface of the true cords to the inferior aspect of the cricoid cartilage. So this is a very important subdivision that is very relevant for us in reporting. Now coming to some important anatomical structures on a CT scan of the neck. So this is the sagittal section and this is the axial section of the neck, and on this sagittal image what we can see is we can see the epiglottis extending from the posterior aspect of the thyroid cartilage to the base of the tongue. This particular cartilage is the epiglottis, and we can see this glossoepiglottic fold and we can see the space which is called the vallicula. There is another space here which is filled with fat, hypodense, homogeneously hypodense fat, that is the pre-epiglottic space. We'll come to the importance of all these spaces later on when we discuss the staging of the laryngeal carcinoma. But for now, you should at least be able to understand that how on imaging these spaces look. So this is the vallicula, this is the epiglottis, the glossoepiglottic fold, and this is the pre-epiglottic space containing fat. This particular structure is the aryepiglottic fold extending from the epiglottis to the arytenoid cartilage. On axial sections, these are the aryepiglottic folds. This is the epiglottis, and this particular space filled with fat is the pre-epiglottic space. These are the piriform sinuses, which are a part of pharynx. So now coming to the axial section just below the section that I showed on the previous slide. So these are a pair of false chords and these are a pair of true chords. So how do you differentiate between the two? The false chords are above the true chords and they are separated from each other by a space called the ventricle. So the true chord level, the landmark that has to be remembered here is the cricoarytenoid joint. As you can see that the arytenoid cartilages are very well visualized here at this level, which is not seen at this level. Second important thing is the paraglottic space which contains fat is very well visualized at the false chord level, which is not seen at the level of glottis, as you can see. And you can see that how the true chords actually intersect anteriorly to form the anterior commissure. And this is the coronal section where we can actually appreciate the false chords, the ventricle and the true chords. So now discussing the T staging of laryngeal carcinoma. So for the supraglottis, glottis and subglottis, T1, T2 and T3 stages are different, but the T4 stage is common for all. For the supraglottis, T1 is where the tumor is actually limited to one subsite of supraglottis with normal vocal cord mobility, involving the suprahyoid epiglottis, aryepiglottic folds, false cords and arytenoids. While in T2 it invades the mucosa of more than one adjacent area with normal vocal cord mobility. That is involvement of glottis, region outside the supraglottis, that is base of tongue, vallicula. T3 is limited to larynx with vocal cord fixation and invasion of any one of the following structures. That is inner cortex of the thyroid cartilage, paraglottic space, pre-epiglottic space and post-cricoid area. Coming to the glottic carcinoma, which is the most common, the T1 stage is where the tumor is limited to the vocal cords with normal vocal cord mobility. It may involve the anterior or posterior commissure. T1A is limited to one vocal cord, T1B involves both the cords. T2 extends to the supraglottis and or subglottis with and or impaired vocal cord mobility. T3 is limited to larynx with vocal cord fixation and or invasion of the paraglottic space or inner cortex of the thyroid cartilage. Now, T4 stage is where there is moderately or very advanced disease, where T4A is moderately advanced disease and T4B is advanced local disease. T4A involves the outer cortex and the thyroid cartilage, invades the cricoid cartilage, invades the tissue beyond the larynx, that is extralaryngeal spread into the muscles of the tongue, strap muscles, thyroid gland, esophagus. T4B, it invades the mediastinum, prevertebral space and the carotid artery. So now we'll discuss a case of a 50-year-old male who's a chronic smoker, and we'll try to determine the extent of the tumor here. So I'm scrolling from cranial to caudal direction. There's a contrast enhanced scan of the neck. Also, always get a scan of the thorax also done along with the neck scan. This is the uvula, this is the oral cavity, and this is the oropharynx. So as I'm scrolling down, I can see that the right vallecula is completely involved. The aryepiglottic folds are involved. The supraglottis and the glottis region are also involved by the tumor. So I'll scroll a bit slowly now. You can see this is the right vallecula, the glossoepiglottic fold. The aryepiglottic folds are also involved here. There is involvement of the false cords in the paraglottic space. The tumor is extending beyond the laryngeal cartilage, that is thyroid cartilage, to involve the strap muscles. So it's a T4 disease. These are the coronal sections where again we can see this mass lesion, heterogeneously enhancing mass lesion, involving the glottis, centered at the glottis and involving this extending up to the supraglottic region. These are the sagittal sections where we don't see the pre-epiglottic. This is the epiglottis. We don't see that pre-epiglottic fat that I showed you on the images. A lung window where there was no obvious mets, but there was some paraseptal emphysematous changes, which is proving that he's a chronic smoker. Now this is the report I had given, that heterogeneously enhancing mass centered in the glottis, which involves bilateral true cords, false cords, paraglottic fat, anterior commissure, both aryepiglottic folds, right vallecula, glossoepiglottic fold, preepiglottic fat, lingual surface of the epiglottis. There was involvement of both anterior thyroid lamina with resultant extralaryngeal extension involving strap muscles. There was no subcricoid extension. So the main important thing to be described in the reports are all the spaces and all the structures of the larynx. So hence anatomy is of utmost importance. So this is a T4 disease, as I had discussed in the staging system.